Good morning, respected esteemed faculty members and my colleagues. On the behalf of Department of Cardiology, I, Dr. Raviraj Singh Mahada, welcome you all in the Clinical Ground Rounds 2024. Topic for today's discussion will be non-coronary peripheral interventions. In the cardiology department, the most common, the percutaneous coronary intervention that are performed that involves the coronary arteries. However, in the past 20 years, major developments have taken place in a non-coronary transcatheter cardiac procedures. The patient which were treatable only by surgery, they now can be offered the percutaneous alternatives. These procedures are often technically challenging, careful monitoring and follow-up. I'll be presenting the analysis of our last 10 years data, that is from 2013 to 23, followed by my friend Dr. Sumang will present a brief review and conclusion. Last one decade, the total number of non-coronary peripheral interventions that are performed in our department are 162, in which the pediatric age group were around 10%, and the patient with more than 40 years of age were around 50%. That is, the majority of the patients were of more than 50 years of age. The mean age was 43 years, with the male to female ratio was 60:40. Out of the total number that were peripheral intervention performed from 2013 to 23, the majority of the procedures that were performed were the aortic procedures that were around for 30%. The next common procedure performed was renal stenting, and followed by the intervention in the obstructive cardiomyopathy. The other procedures that were less commonly performed were carotid and subclavian stenting, iliac femoral interventions, the catheter-directed thrombolysis, and ruptured sinus of Valsalva devices. Of the aortic procedures that were performed, the most common procedure performed was the coectoplasty. In the renal artery intervention, the most common procedure performed was the renal artery stenting, and in the hypertrophic obstructive cardiomyopathy, the most common procedure performed was the alcoholic septal ablation. Now I'll hand over the stage to Dr. Sumang. He will continue with the cases, discussion, and the brief review. Thank you.
Good morning, respected faculty members and colleagues. I shall be covering the following spectrum of cardiac diseases, briefly outlining their salient features and available data pertaining to intervention versus surgery, the current available recommendations, and some of the prototype cases done by us. Coarctation of aorta constitutes 6 to 8% of all congenital heart defects and is often associated with the bicuspid aortic valve and Turner syndrome. Clinical presentation is bimodal, with neonates and infants presenting with heart failure, while older children and adults often present with hypertension that may be detected incidentally. Investigations that are often helpful include an ECG that shows left ventricular hypertrophy, an X-ray that shows the 3 signs indicating the pre and post stenotic coarctation segments, and rib notching. Although an echocardiography is usually diagnostic, prior to intervention, a CT is considered mandatory. Relief of obstruction is the definitive treatment, and without this, only 1 in 10 survive till 6th decade. With early intervention, risk of residual hypertension is less than 5%, while 30 to 50% of those treated at an older age may have residual hypertension. The modalities of treatment include surgery versus balloon angioplasty versus stenting. Intervention is only done if gradient is more than or equal to 20 millimeter of mercury across the coarctation, and only in the presence of left ventricular hypertrophy, hypertension, and left ventricular dysfunction is intervention recommended in presence of lower gradients. Meta-analysis comparing balloon versus surgery have conclusively shown that while balloon angioplasty has good initial results, over long term, surgery is better due to lower need of redo procedures and recoaptation. Contemporary data for stenting in coarctation has shown stenting to be safe and having better gradient reduction. Hence, if the size of the aorta permits, stenting is a good choice for treatment. The Indian guidelines, they recommend that for neonates and infants, surgery should be preferred, and only if the baby is critically ill or in severe heart failure, balloon angioplasty be recommended. For children less than 25 kg, balloon angioplasty is preferred, while for children more than 25 kg and adults, stenting can be done. And stenting should be avoided in patients less than 10 years of age. We now come to our case of coarctation, where a young hypertensive male presented to us with lower limb claudication for last 3 years. On examination, he was found to have feeble pulses in both lower limbs with upper limb hypertension. His ECG was done that showed left ventricular hypertrophy, and his chest X-ray was suggestive of rib notching. His CT angiogram confirmed the diagnosis of severe postductal coarctation of aorta, and patient was taken up for coarctoplasty procedure. We tried to negotiate the channel anterogradely using a stiff Gaia wire that initially entered the subintimal plane, and we had to redirect it into the true lumen. This highlights the challenges that are faced in such lesions with such severe stenosis. Once we could cross the Gaia wire, it was externalized using a snare and thus creating a railroad over which subsequently sequential balloon dilatation were done. Following this, a 14 into 45 millimeter stent was positioned and deployed, and a good final result was achieved as seen in angiogram. These are the simultaneous pressure tracings of ascending aorta and descending aorta across the coarctation, and post-procedure pressure tracings show zero gradient. Following this, the patient was successfully discharged after 24 hours, and at follow-up of nearly 2 years, patient is now asymptomatic. This is just a quick look at the total coarctoplasty procedures done by our department, where the mean age was around 28 years, and there was a satisfactory reduction in gradients following the procedure. There were no peri-procedural complications. The second spectrum of aortic intervention we shall discuss is aortic aneurysm with or without dissection. An aneurysmal aortic segment is defined as dilatation of aorta with diameter more than or equal to 50% than expected. And it usually involves either abdominal aorta or thoracic aorta or both. And it may either rupture or dissect. Such patients may present with a pulsatile mass, breathlessness, chest pain, and other signs of rupture with or without hypotension. The classification is based on the site and extent of the dissection flap, whether it involves ascending aorta, arch, or descending aorta. Those that are within the arch or descending aorta are often amenable to percutaneous closure. Investigations that are used include an X-ray and echo that can often show the dissection flap and the associated aortic regurgitation. However, CT delineation of the anatomy is a prerequisite before intervention. Open surgical repair has been the standard of therapy, wherein a prosthetic graft is anastomosed to the non-aneurysmal aortic tissues. With recent data on endovascular repair, covered stents have been used to manage these cases via a percutaneous approach. And even in patients with arch vessel involvement, hybrid procedures with aortic debranching can be done, a case that I'll show in some time. The landmark trials like EVAL-2 and DREAM, published in 2016 and 17, showed that although elective endovascular repair results in a lower initial perioperative mortality than traditional open repair, the early advantage disappeared over time due to higher redo procedures in the endovascular repair arm. Using the new generation stents, later trials in 2024 comparing surgery versus endovascular repair showed that the long-term results were comparable to surgery. The current guidelines recommend that for patients with suitable anatomy, that is aneurysm size of more than 5.5 centimeter, endovascular repair can be preferred over surgery. It is, however, important to remember that post-endovascular repair, lifelong surveillance is needed with annual CT or ultrasound to detect any sac expansion. Now, coming to our aortic aneurysm dissection case, a 48-year-old hypertensive male, he presented to us with sudden onset chest pain and diaphoresis. He had hypertension and tachycardia, and we initially suspected a diagnosis of acute coronary syndrome, which was later ruled out by a normal ECG and negative troponin. An echocardiogram was done, which showed a dissection flap in descending thoracic aorta. This was confirmed in CT that showed a descending thoracic aorta aneurysm with dissection flap distal to left subclavian artery. So, a diagnosis of Stanford type B aortic dissection was made, and a hybrid procedure for the patient was planned, wherein a 6 millimeter Gore-Tex graft was placed between left common carotid artery and left subclavian artery in the cardiovascular OT, and patient was shifted to cath lab for thoracic endovascular aortic repair. The sizing of dissection segment was done using a graded pigtail catheter, following which the stent graft was positioned and deployed. The final result was satisfactory, and patient was later extubated and discharged after 3 days. This case was done in January, and at 1 month follow-up, the patient is asymptomatic with well-controlled BP. The third spectrum of aortic intervention involves Takayasu arteritis, that is a granulomatous large vessel vasculitis involving the aorta and its branches. The course may be self-limited or progressive, causing severe vascular obstructions. Based on the site of involvement in the arch ascending aorta or thoracoabdominal aorta, the disease is classified into various subtypes. Patients may present with constitutional symptoms like fever, joint pains, night sweats, or end organ involvement depending on the vasculature involved. And hypertension due to renal artery involvement, upper limb claudication due to subclavian vasculature involvement, and giddiness or syncope due to carotid vasculature involvement are common modes of presentation. Although echocardiography can often localize the site, CT or direct angiography are the diagnostic techniques. While the medical management of active disease requires steroids, immunosuppressants, and biological agents, stenotic lesions often require intervention like balloon angioplasty, which, although cost-effective, can be associated with acute dissection and has high restenosis rates of up to 20 to 30%. Using cutting balloons with or without stents can produce better luminal diameter and has a lesser restenosis rate in the large vessels, that is up to 5 to 15%. Surgery is generally reserved for long diffuse lesions, especially restenosis, post-angioplasty or stents. The largest contemporary data in this regard has been recently published by the Velour Group, headed by Dr. George Joseph, providing insights into endovascular management with long-term favorable results up to 15-year follow-up in more than 85% cases. According to their data, stenting in Takayasu arthritis is safe and effective, especially when done in the non-active stage, and it should be offered earlier rather than later in the course of the disease. The Indian data has suggested a few important points. Firstly, intervention should be avoided in active disease states. Then elective stenting in osteal lesions, fibrotic lesions, and resistant lesions should be considered. Staged revascularization for carotid disease, and stenting should be avoided in long lesions of subclavian vessels. Now coming to our Takayasu arthritis case, an elderly female who was hypertensive, diabetic, and having chronic kidney disease presented to us with exertional dyspnea for last 1 year. She was found to have resistant hypertension and her BP was poorly controlled despite 3 antihypertensive drugs. On examination, she had feeble lower limb pulses along with an audible abdominal bruit. On abdominal ultrasound, her infrarenal part of abdominal aorta was not visualized. MR angiogram showed total cutoff of abdominal aorta below the origin of renal arteries and a diagnosis of aortoarthritis with total abdominal aortic interruption was made. Patient was planned for diagnostic angiogram followed by elective angioplasty. The angiogram confirmed total interruption of abdominal aorta below the origin of renal arteries. We attempted to cross it using multiple wires, gradually escalating to stiffer wires, and finally it was crossed with a stiff conquest wire. Following this, serial balloon dilatations were done with balloons of increasing sizes. This was the final result achieved with an adequate sized aortic lumen after elective balloon angioplasty, and the simultaneous pressure tracings of ascending and descending aorta showed significant reduction in gradients from 70 millimeter of mercury to 15 millimeter of mercury. Patient was later discharged and is doing well on follow-up with adequate BP control on a single antihypertensive agent. We now move to hypertrophic cardiomyopathy, that is a genetic cardiomyopathy with disproportionately increased left ventricular septum thickness. Patients often present with classical symptoms of left ventricular outflow tract obstruction and occasionally with sudden death due to ventricular arrhythmias. Apart from ECG showing left ventricular hypertrophy, an echo is diagnostic and shows the severe hypertrophy of interventricular septum, along with systolic anterior motion of the mitral leaflet that produces dynamic left ventricular outflow tract obstruction. While medical management revolves around beta blockers, calcium channel blockers, and diazopyramide, the latest addition to this is mavacamten, that is an inhibitor of the cardiac myosin ATPase. However, the definitive therapy is septal reduction therapy, which is either surgical or ablative. Surgical myectomy with muscle resection to the level of papillary muscles is considered as gold standard, and the second modality is alcohol septal ablation, wherein a balloon is inserted into the septal artery and alcohol is injected to produce localized septal necrosis and therapeutic infarction. Comparing alcohol ablation with myectomy, recent meta-analysis report that alcohol ablation has lower peri-procedural complications, but higher pacemaker implant and re-intervention rates, while myectomy, if done adequately, has better long-term gradient reductions. Surgery is especially reserved for primary mitral valve disease with moderate or severe mitral regurgitation. Here I want to highlight the fact that patients with severe hypertrophic obstruction associated with severe mitral regurgitation are not candidates for septal ablation, but they should be primarily offered surgery by experienced surgeons. This is one of the cases that was done at our institute in the surgery department, where the patient had hypertrophic obstructive cardiomyopathy with severe MR. His septal myectomy was done that led to the abolition of MR as seen in the echo video on the screen. So this is just to highlight that case selection has to be very stringent and correct. The guidelines recommend that patients with gradients more than 50 millimeter of mercury and symptomatic despite drugs should be offered septal reduction therapy. An alternative method to produce a localized infarction is to perform coil embolization of the septal artery. We will now discuss two cases of hypertrophic obstructive cardiomyopathy where ablative therapy was done in our department. The first case, where a young male, he presented to us with angina, dyspnea, and presyncope for last 3 years. On examination, he had a systolic murmur at base that increased with Valsalva. His ECG showed incomplete right bundle branch block, and his echo confirmed the diagnosis of dynamic left ventricular outflow tract obstruction with a gradient of 60 millimeter of mercury. He was previously taking 100 milligram of metoprolol per day. The diagnosis of HOCM was confirmed and patient was planned for septal ablation. The pressure tracing showed a significant gradient of 60 millimeter of mercury between left ventricle and aorta, along with the characteristic spike and dome pulse of hypertrophic obstructive cardiomyopathy. For the procedure, the left main coronary artery was hooked with a guiding catheter and septal artery was wired with temporary pacemaker backup. The balloon was inflated in septal artery and 2 ml of absolute alcohol was injected. This produced therapeutic septal infarction and abolition of left ventricular outflow tract gradients. Patient was asymptomatic at 1 year follow-up with no increase in gradients. The second case of HOCM, where the patient had angina and exertional dyspnea for 6 months, and echo confirmed the diagnosis of dynamic LVOT obstruction with a gradient of 170 millimeters of mercury. This patient was previously taking oral metoprolol 100 milligram twice daily. Patient was taken up for septal coiling procedure. His left coronary artery was hooked with a guiding catheter. Septal artery was wired and the coil was deployed using a microcatheter in septal branch. The final result shows coil in situ and a drastic decline of gradient was seen to 30 millimeters of mercury. Patient was asymptomatic at 1 year follow-up with no increase in gradient. This is a snapshot of our HOCM data, and it shows an acceptable reduction in gradients and only a single case who needed peri-procedural pacemaker implantation. Moving on to the pulmonary vasculature, patients of pulmonary embolism often present with dyspnea, chest pain, pre-syncope, syncope, hemoptysis, and hemodynamic instability. Show acute right ventricular strain with S1Q3T3 pattern and incomplete right bundle branch block, while echo shows a dysfunctional right ventricle. Echo often may show clots in transit in the right atrium along with severe tricuspid regurgitation and severe pulmonary artery hypertension. CT is the imaging modality of choice and may show a saddle thrombus or branch pulmonary artery thrombus. While guidelines recommend thrombolysis as a class 1 indication, catheter-directed pharmacomechanical approach is also recommended for those with failed thrombolysis or when thrombolysis is contraindicated. These approaches often use ultrasound disintegration of the clot or mechanical aspiration with a suction source to achieve percutaneous thrombectomy with the device called the penumbra device. Recent trials using this device have consistently shown benefit with acceptable procedure time, short ICU stay, and improvement in right ventricular function. Now coming to our case of catheter-directed interventions, an elderly female presented to us with sudden onset of dyspnea. She had a previous history of lower limb deep vein thrombosis 3 years back. On presentation, she had hypotension and tachycardia. Her ECG showed the characteristic S1Q3T3 pattern of pulmonary embolism along with right bundle branch block, and echo showed severe pulmonary artery hypertension. Her CT had been done outside that was suggestive of acute pulmonary embolus in right pulmonary artery, and she had been thrombolized outside with altiplase. Considering failed thrombolysis and in view of massive pulmonary embolism, as suggested by hemodynamic instability, she was taken up for catheter-directed pulmonary thrombectomy. Her pulmonary angiogram was done using a long sheath and thrombectomy was done using penumbra catheter. And her right ventricular systolic pressure got reduced from 80 to 40 millimeters of mercury. An adequate final result was achieved. Patient's hemodynamics improved and patient was successfully discharged after 1 week on oral anticoagulants on oral anticoagulant therapy. And she was doing well on 6-month follow-up. Coming to another case where an elderly female with severe rheumatic mitral stenosis presented with left lower limb pain with absent pulses for the last 4 days. Her initial ECG was suggestive of atrial fibrillation, and she was in sinus rhythm during the echocardiographic examination. There was complete thrombotic occlusion of left common iliac artery on Doppler and a diagnosis of rheumatic mitral stenosis with paroxysmal atrial fibrillation presenting with acute limb ischemia, probably of cardioembolic etiology, was made, and patient was planned for catheter-directed thrombolytic therapy. Angiogram confirmed the Doppler finding of total thrombotic occlusion of left common iliac artery, which was then thrombolized using intra-arterial urokinase in a dose of 250,000 international units bolus, followed by 100,000 units per hour for the next 48 hours with pigtail catheter in situ. Her check angiogram was done at 48 hours, showing a patent vessel with normalization of pulses, and she was later discharged on oral anticoagulation. Be presenting some case examples of peripheral vascular interventions done in our department. A case of carotid vascular intervention where an elderly female presented to us with history of left hemiparesis 2 months back. She had a carotid buoy on examination, and her CT angio showed severe stenosis of right internal carotid artery. She was taken up for invasive angiogram that confirmed the CT angio finding of severe stenosis in right internal carotid artery. The segment was wired using an angioplasty wire, but the filter wire could not be negotiated due to tortuous vessel. Following this, balloon pre-dilatation was done. The stent was positioned and deployed. A satisfactory final result was obtained, and patient was discharged after 24 hours and is doing well on 6 months follow-up with no significant neurologic deficit. Another case example where an elderly male presented to us with upper limb claudication for the last 6 months with feeble left upper limb pulses and significant blood pressure difference between both the upper limbs. His CT angiogram showed total occlusion of left subclavian artery. Invasive angiogram confirmed the total occlusion of left subclavian artery. We tried to cross the lesion with softer wires, but it could not be crossed. And finally, we were able to cross it with a stiff conquest wire. Following this, balloon pre-dilatation was done and stent was positioned and deployed. An adequate final result was with equalization of pulses and BP in both upper limbs, and patient is asymptomatic on 2-year follow-up. Coming to the case of a 19-year-old boy who had tonic-clonic seizure episodes along with diminution of vision in both eyes with accelerated hypertension. He was being treated as hypertensive encephalopathy elsewhere, but his BP had failed to respond. He also had bilateral exudative retinal detachment and multiple occipital infarcts, and patient later developed acute kidney injury. During the hospital course, he had recurrent pulmonary edema needing ventilatory support. Further evaluation revealed total cutoff of left renal artery after origin and a diagnosis of renovascular hypertension presenting with hypertensive emergency was made. Patient was taken up for invasive angiogram, but on angiogram we couldn't find the left renal artery stump. We probed for the stump and we were successful in creating a nibble, which was then negotiated using a stiff wire. This was followed by serial balloon dilatation, followed by stent deployment. This was the final result, and following this, patient's vision improved, his BP settled, and we were able to discharge him on a single antihypertensive agent. This is a compilation of our data of renal vascular intervention, which shows that there was a significant reduction in number of antihypertensive drugs and their doses post-procedure. Coming to a case of iliac artery intervention, where an elderly male with history of percutaneous transluminal coronary angioplasty in 2007, he presented to us with left lower limb claudication with diminished pulses on examination. His ECG and echo were normal. On invasive angiogram, patient was found to have severe stenosis of left common iliac artery, which was dilated and stented, with a satisfactory final result and restoration of pulses. Patient is now doing well or at 1 year follow-up without any complaints of claudication. Coming to this final case of a young female with history of PDA device closure that was done in 2019. She presented to us with cough and expectoration for last 2 years. Her cardiovascular examination was unremarkable, but her saturation on room air was 92%. Her chest X-ray was done, which was suggestive of space occupying lesion in left lower lung field. Her echo was suggestive of PDA device in situ without any residual shunt across the device. Following this, CT angio was done that showed two pulmonary AV malformation of 2.4 into 2 centimeter in the right lower lobe, and a larger one of 5.4 into 5.2 into 5 centimeter in the left lower lobe with feeder vessel from left pulmonary artery. Left-sided pulmonary AVM being the larger one, so we decided to target it first. The cocoon duct occluder was deployed in the feeder vessel, which was successfully occluded. This was the final result obtained. Patient's hemoptysis settled, and on 1 year follow-up, we repeated her CT, which showed regression and thrombosis of the left-sided pulmonary AVM. Thus, to conclude, these non-coronary interventions encompass a spectrum of cardiac conditions ranging from aortic diseases, hypertrophic cardiomyopathy, pulmonary, and peripheral vasculature. And advances in interventional cardiology have dramatically expanded the therapeutic options for these patients who were once only offered surgery. Selected patients with suitable anatomy can now be offered balloon angioplasty, stenting, and endovascular repair. And case selection should be judicious, and because these procedures are often technically demanding, and if successful, they can obviate the need for surgery. Thank you.